Well, there's the recording, so that's great. Yeah, and welcome her, Carole. It's nice to meet you in person. For me, I've heard about you, so it's very nice to see you in person. And so maybe we'll go around, and if the residents, we'll start with Tyson in BC and maybe wind our way across the country.
Sounds good. So I'm Tyson Rosardo. I'm one of the PGY6 Geriatric fellows out in BC right now. It's nice to meet you this morning.
That might be it for BC. Anybody from Alberta?
Hey, I'm Raheem Solomon. I'm one of the PGY6 fellows at the U of A. So nice to meet everyone.
Nice to meet you too. Anybody from Edmonton today?
I'm also from
provinces. Oh, go ahead. You're it, are you?
I think I'm it from Alberta.
Okay. Any more prairie provinces, people?
Sorry, I'm going to quickly interrupt. I'm Eric Paulson. I'm from Prince George, BC. I just dropped in a moment ago, so I think I missed the initial introduction there. But also from British Columbia.
All right. So are you struggling in the snow as well?
It is very cold, yes.
Yes.
We have lots of it.
And did you get the introduction of Carole Cohen, who is our speaker today from University of Toronto, talking about capacity? And we're just introducing everyone so Dr. Cohen can know who she's speaking to today. So do we have anybody from the prairie provinces? Ontario. There's got to be a few. Any U of T people?
Don't see anyone.
Queens, Western. All right. So what about Nova Scotia?
It's Mackenzie. I'm a R5 jury fellow.
Anyone else here? Is Amy here?
No.
No, don't see her. Newfoundland?
Hi, I'm Jessica. I'm from Newfoundland.
Hi, Jessica.
PGY6 Geriatric.
All right, and I'll just quickly go through the list. Did we meet
Quebec? We forgot Quebec.
Quebec. Oh, there we go.
Yeah,
I was
waiting to see if you are.
Yeah.
But yeah, I'm from Montreal. Vincent Jeté-Pomerleau. Nice to meet you all.
Nice to meet you.
And sorry for joining late. I'm Harry from Calgary.
Fantastic. Okay, just looking at the names, it looks like we got everybody. Did we meet Kaina?
She is the program administrator from UBC. She may be here.
Right. I'm just here to take attendance. Hello. There we go. Okay, I think we're good. And we'll let Carole Cohen get started. And she's willing to take questions as we go through, and also we can have conversation at the end. So we'll hand it over to you.
Perfect. I'm glad the car stopped honking in the parking lot behind me, so we can go from there. So it's lovely to meet you folks, and I apologize to anybody who's seen me give some of this talk before, because I have given it in different places, and again, I apologize if it's redundant for you, and I am happy to entertain questions and to learn from you, because this is such a challenging topic to do cross country, because the jurisdictions are so different and the legislation is so different. And so I really look forward to learning from you folks as well. So some disclosures and acknowledgements. I have had this really interesting job, which is about to come to an end at the end of the fiscal year in March. I've been a consultant to what's called the Capacity Assessment Office of the Ministry of the Attorney General in Ontario. We have this cadre of individuals called capacity assessors. I am not one of them, but I've been privileged to help shape their training and to supervise them for many, many years, and it's been a fascinating process. And I also wanted to thank Ken Schulman, who's my colleague and mentor, and Janet Munson, who was one of the other original consultants to the Capacity Assessment Office and who developed some of the guidelines, people for sharing their wisdom with me. So I wanted to talk a little bit about decision-making in terms of the concept, give you some ideas about my ideas for process for assessing decision-making capacity, and again, being very well aware of the fact that the laws differ so much across the province, and then just to talk a little bit about how they might be used locally and to hear from you. So first thing I wanted to do, and again, I apologize, I can't see you all now because I've got my slides up, but anyone be brave enough to tell me about your experiences in dealing with consent capacity issues, assessing capacity, because it's different in different provinces, and what your learning needs might be, what you hope I talk about today. Anybody brave enough to share with us? Because I know some of you, go ahead.
I'll throw in, so the experience, some of the experiences, one of the more complex cases that comes to mind is an individual who had sort of a multi-domain capacity sort of questions, sort of staggered over time, where some of the initial questions came about for the initial financial capacity and management thereof within financial abilities, which then eventually turned into relational sort of capacity related to their ability to go, or decisions around returning to their home dwelling versus placement to a long-term care facility, specifically in the context of somebody with severe hoarding and severe sort of difficulty managing their home environment from a safety perspective. And then eventually, sort of in between, there's also questions around capacity for medical decisions because they became medically compromised during the whole process.
Fantastic, Tyson. So I can take that case study and we could put it on my slides and we could use it because that's great. So you've highlighted a whole bunch of issues. One is the multi-domain aspects, the fact that things evolve, and then some of the complexities in the situations that we deal with, like hoarding and how to kind of get our head around that, and moving to an independent, being discharged to an independent dwelling, moving to long-term care, and the legislation differs for all those things. Thanks so much. That's really helpful. Any other reflections, thoughts, or things you wanted me to try to address?
I think one area that I find really challenging is when you have somebody, it could be, for example, like a substance use issue is involved, or I'm about to see one shortly where the person was inappropriately giving themselves insulin, like didn't know how to manage their diabetes very appropriately. And so since that has been regulated, the person has had a significant improvement in terms of their cognitive functioning. But I guess the fear is always that, if you then say that this person is now capable, are we just right back where we started, right? So at what point you kind of make that decision and say, we've done this how many times, the person is no longer capable.
Brilliant. Again, two issues that come up very, very early when I start talking about this, which is substance use disorders and how do these legislations help or not help with that. And that challenge of seeing somebody who's now in the hospital setting or in a structured setting where all those problems everyone was going crazy about are now settled, and how to have a discussion about that. Yeah, very, very challenging. Thank you. Okay, now that we brought all the challenging stuff up first, any other thoughts? And again, hold me to that. So we need to get back to those topics if I don't.
Can you hear me? I wasn't sure if my sound was working before.
I can hear you now.
Oh, perfect. One thing I find challenging is doing treatment capacity, or when there's capacity issues around treatment in the outpatient setting compared to the inpatient setting in terms of like logistical issues. So if someone's made incapable in the hospital and they continue into the outpatient setting, it's a bit easier, but managing when someone doesn't have capacity, you're seeing them in the outpatient setting, and how do you manage when you feel they need medications, but they're not interested and you don't have the setting of a hospital to help support administration of medications in those settings. I find that always really difficult.
Absolutely. As a community psychiatrist, I totally relate to that. Dealing with a lady I met only through her care team on Monday, and now she's in hospital, admitted within 24 hours. And everybody's talking about how would we ever get medications into her for her delusional disorder in the community. So absolutely. Thanks so much. That's a lot of interesting thoughts and things for us to chew on. So I like this definition. It's a pretty neutral one. Arlene Pache is a psychologist in Alberta. And again, the scheme there is very, very different than it is in my province in terms of involvement of different healthcare professionals and doing different kinds of assessments of capacity. In Ontario, for instance, we don't, physicians wouldn't be involved in any financial capacity assessments outside of an inpatient unit, whereas I know in other provinces that's not the case. But Arlene has talked about just generally capacity being the ability to use cognitive processes, and I've highlighted that because most of the legislation in jurisdictions in our country and abroad looks at it as a cognitive process. And then we got those words that you might begin to remember and see in your own legislation where you work. Understand and identify options. So there's that understand word, and appreciate consequences of different options. And then the last one, which is an interesting one, follow through with chosen options. So in Ontario, for instance, there's a lot about ability to understand, and that word ability becomes very important in Ontario and other jurisdictions, and ability to appreciate. But there's nothing about following through. And so that's often interesting, is how do we fold that into our legislative schemas, and what do we do about that? Because some people can talk the talk, but can they walk the walk? And what do we do about that, and how do we deal with that? So this is a general definition to start with. And as you probably are very aware from your training, and you're all senior residents, the times where we're going to be asking ourselves, is capacity, decision-making capacity an issue, is often broadly speaking in these 4 groups. In Ontario, the capacity assessors kind of think about these 4 broad groups and actually have to self-identify of which of these groups they would feel comfortable doing an assessment of capacity with. So people with intellectual disabilities, again, a very different group where they might be gaining abilities over time, but may not have those abilities or ever have them. People with psychiatric disorders, where people might have intermittent difficulties with decision-making capacity. The group that we're often dealing with, of course, neurodegenerative disorders, where people are losing decision-making capacity. And then a whole host of acquired neurological disorders. We want to put people who've got acquired brain injury and other kinds of neurological disorders in that. So that's kind of broadly speaking where many people think about that. And it's interesting to think about that, because people in these different groups are going to have different abilities neuropsychologically and cognitively, and different disabilities or limitations. And so there might be different lines of questioning or different ways of approaching these different populations. So what capacity is, it's very much task specific, and Tyson's talked very helpfully about the fact that there's many different domains that we're looking at: treatment, placement, et cetera, et cetera. One could be capable of one and not the other. Simple example would be one might be capable of granting power of attorney, for instance, understand what it is to grant Tyson power of attorney to manage my property, but I might not be able to myself manage my property because it's too complicated. I've got a whole bunch of investments and houses and other things that I've got to manage. It's very much situation and context specific, and you've already started to hear from your colleagues about some of the situations that people are dealing with. So how do we ask someone questions about their situation, their context, not somebody else's? So if I'm reading, for instance, an assessment by a capacity assessor in Ontario who's gone to see someone in a long-term care home, and they're asking them about the cost of a loaf of bread, well, that doesn't really seem very context specific. And I can imagine a lawyer questioning them right away to say, what does that have to do with their financial situation living in a long-term care home? Their meals are all provided for them. So really trying to figure out how to make it situation specific, context specific for that individual. And then the other one is jurisdiction specific, and there's different laws in every single province and territory, different laws in every single state, and different laws across the world. And that's what makes it so challenging, reading journals from other jurisdictions, training in one jurisdiction and moving to another. So I've met many residents who really have to sort of start from square one when they move jurisdictions, either to pursue subspecialties training or when they become staff and then have to move to a different province and learn the whole system. I met for a delightful coffee this summer with a resident who trained here in Ontario, moved to BC, and it's taken her months to figure out how all the parts of the legislation in that jurisdiction works. So that's really an interesting challenge for us across Canada. So what it's not, and this is a short list, we could make it a longer list, it's not education about a decision. So I was talking to a new capacity assessor yesterday about his first assessment. He's getting ready to go out and he's going to see a gentleman in a retirement home who had his sister managing his finances, but she's resigned. And the lawyer called the capacity assessment office looking for an assessor because this gentleman doesn't seem to understand his finances, doesn't understand his situation. But it's not clear whether anyone's educated him about it, on how long he's not been dealing with it. And so how does one assess capacity if he's never really had an opportunity to learn about his current situation? Just like if someone's widowed and their spouse always dealt with the financial situation, and then someone wants to know if the surviving spouse is capable of managing property, well, they may never have managed it before, and so they need some education. And that could go for any decision you're asking somebody about with respect to treatment or other kinds of things. It's not a score on cognitive testing. And to my chagrin, many lawyers now do cognitive testing and use screening tools and think that's helpful. There is some evidence that maybe executive functioning and processing speed might be more predictive of lack of capacity, but there's no clear correlation. As you know, you can meet people whose MoCA score is quite high and can be incapable with respect to certain decisions, but there is no sort of number that helps you feel comfortable. It's not agreement with us. It's not determined by the diagnosis. It's not low risk behavior, and it's not wishes. Many folks are frustrated because someone talks about something would like, a patient or a client, and then that's taken as a capable wish, and sometimes it's not a capable wish at all. So the other thing I wanted to highlight, and this is so clear when I begin to work with new capacity assessors like this gentleman I was talking to earlier in the week, is taking that hat off as a clinician and then putting a hat on as someone who is assessing capacity and what the similarities and differences are. And sometimes it's challenging to make that pivot or transition. So in clinical assessments, we're making a diagnosis and treatment. The diagnosis might be a differential diagnosis. We want to solve problems. We're trying to do what's best for our patients or clients so they'll thrive. We're going to do a mental status. We're probably going to do or get from someone else some cognitive testing. We're going to either do or get from someone else a functional assessment. And those are all going to be important things we want to know. I mean, can that person go to the bank? No, because they're not able to. Well, that doesn't speak necessarily to their capacity to manage their finances, but it speaks to the fact that they have a situation they're going to have to deal with. Whereas in capacity assessments, we have to make a capacity determination. And this is where the challenge is, right? We have to say yay or nay. And that's often difficult. We can't have a differential diagnosis or a list or a maybes. And often the way I like to think about it, and the challenge is, do we have enough evidence to override the presumption of capacity? Because in most jurisdictions, and in most laws, we're asked to assume someone's capable. So do we have enough evidence to override that presumption of capacity and to say that the person's incapable? That might result in their rights being removed. It would be a specific line of questioning regarding decisional capacity. And there may be specific legal requirements or forms which you need to learn about in your specific province in terms of how you do this, how you document it, and what kind of rights advice or other things you do. So there are slight differences. In Ontario, for instance, I hate to keep returning to that, the capacity assessors are all clinicians. So they chose them. Initially, there were lawyers that were allowed, but it was clear that the lawyers were struggling because the interviewing skills are so important to keep someone in the room and working with you such that you can ask them enough questions to hopefully decide in your mind whether you have enough evidence to decide whether they're capable or not. So the interviewing skills are really, really important. Being a clinician arms you with those skills, but you have to be thinking about a slightly different kind of assessment when you're doing an assessment of capacity. So for me, always when I'm asked, and I like the way Tyson talked about the fact that there are multiple domains, often people will ask me, is someone capable? And the first question I'm going to ask is the one that Tyson was asking, which is capable of what? And the next question I'm going to be thinking about in my province and in my little neck of the woods is, how is that assessment of capacity going to help? Because often people think if I come in and say they're capable or this or that, then somehow, it's open sesame, the door's open, the home and community person gets in to give the bath, that person takes their medications when they don't want to. And often that it might lead to some more problem solving, and it might lead to some fork in the road with respect to who's making substitute decisions or shared decisions, but it might not solve the clinical problem that people are hoping And often I'm talking about lining our ducks up in a row, and I'm thinking about, well, if we do this, it'll lead to this outcome. If we do that, what are the barriers going to be? But it may not be that my piece of paper or my determination of capacity or incapacity is going to solve the clinical problem. And therein lies a lot of pressure on us as physicians, that people are hoping we have some sort of magic that somehow, I know sometimes it does solve a problem, but it doesn't always. So these are my kind of steps 1 to 9 in terms of how I think about approaching an assessment of capacity. Again, trying to keep it very, very broad and thinking about some of the things you brought up, and we probably need to talk more in a fulsome fashion about some of the innuendos that you've brought up in terms of hoarding and substance use disorders, inpatient, outpatient. But let me start with my kind of steps 1 to 9. So the first thing I'm always thinking about is why now? Why are people asking me? What domain? What task? And why is assessment needed? How is it going to be helpful? What are people hoping I can solve? What is that piece of paper or that determination going to do? And where are people at? Why are they stuck? What's the situation? What's the crisis? Have other options, less restrictive alternatives been tried? And even knowing when they were tried, what happened is sometimes helpful, because all of that is explicit information about that individual that you might use to talk to them about their situation. So I hear that such and such was tried. Does that person even remember that such and such was tried? Do they understand that that was tried? Who should be doing the assessment? And that could differ in different jurisdictions in terms of who is mandated to do it. Are there specific legal requirements, rights advice, forms, etc.? So that's what I'm thinking about for the first step. My second step is thinking about what information do I have from others? And that would be about the situation, the context, the risks. And again, risk is often why we're called in, right? Everybody's tearing their hair out. They're so worried. And as somebody said, you know, we're worried that this is going to start all over again. We're going to go around that merry-go-round again. So thinking about risk and how do we factor risk into our questioning? So it doesn't determine the outcome, but it might raise or lower that bar in our mind in terms of the line of questioning, what we think about. Options, what are the options? I mean, again, options depend on people's finances, their social support, the service system you're operating in. I know it would be lovely to have X, Y, or Z in my little corner of the world, but right now it's not available because there is a crunch with respect to so many things. And then what are the demands for this situation and the decision? So how complicated is it? What do people need to do? What needs to be managed with respect to their personal care? Insulin's a big deal. It's much different than taking an oral hypoglycemic. Managing a large estate is much different than managing just a pension check in and a rent check out. So what needs to be managed, and where is that person operating? And can we understand where that gap is? They seem to be operating here and getting this done, but they need to be up here doing this, and there's that little bit of a gap. Can we have a discussion or a give and take about that gap, what needs to be done and why they can't do it? If they can't get to the bank because of a variety of reasons, how could they arrange for someone else to help them with respect to the finances? And then information about cognition and function, again, not going to be determinative just because their MOCA score or their MMSC score is such and such doesn't mean they're capable or incapable, but it may help you in focusing your line of questioning to know that this person's short-term memory is great, but their abstract reasoning is not, or that this person's short-term memory is terrible, or that this person never learned to read or never learned to do these things, and what their functioning is. Can they read, write, walk, talk? How are they going to deal with the decision that they need to make in the context of their functioning? And as I said, what's been tried and the outcome, so that you have that specific information about that individual that you can reflect back to them in the conversation with them. Then I'd like to think about involving the client and educating them. So telling them about the proposed treatment, about their current financial situations, what their home care options are, and then describing what some of the consequences might be and seeing if they can have a conversation with me about the status quo versus potential solutions. And this begins to craft some of the questions you're going to ask them to see if they can compare and contrast the various options that they have. You want to be thinking about optimizing functioning during an assessment. There's nothing nicer than to read an assessment where someone's turned their mind to accommodations. We don't want to find someone incapable because they couldn't hear us, they couldn't understand us because we're not speaking their language. that we talk to them at a time of day that's not a great time, or they've just had their opioid and they're really not with it. So thinking about that, and then even putting that into your write-up so that people understand that you turned your mind to that and we're thinking about that. That's always a very nice way of crafting your report or your reporting. Then clinical considerations would be which of those vulnerable groups, and therefore what do we know about their cognitive functioning and functional abilities, because they belong to that group or because of that specific information you've received about that individual, so that you understand their situation and where their strengths and weaknesses might be with respect to functioning and with respect to cognition, so that you can craft a line of questions that are going to speak to that and maybe help you uncover some problems or uncover the fact that they're doing just fine. Thinking about preferences and values is very, very helpful. You know, that person who was always very frugal with their money, who's now not, that's a change. So how can we have a discussion about that? What can we do about that? I've been asked lately to talk a lot about capacity issues to financial planners and people who help people with financial decision-making, investment, etc. And that's been fascinating to try to help them understand these issues, but also to help them think about their clients, you know, those people who are always risk takers with respect to their financial investments. So the 90-year-old who wants to get into cryptocurrency or cannabis stocks, and, you know, what is that all about? Is that a capable decision, or is that something they always did? They were always kind of on the leading edge of taking a risk, or is this something very new? But do they really understand all these issues? So that's often an interesting kind of area to focus on. Knowing when to consult. So, you know, basically communication difficulties. Do you need a speech language pathologist to help you? Do you need a translator? Legal questions, so you understand the legal framework about what you're doing and how you should be doing it. Help with specific populations. I don't have a lot of experience or training, for instance, in dealing with people with intellectual and developmental disabilities. So I probably wouldn't want to be taking on a formal assessment of capacity with that kind of population. I'd want someone to help me or to be doing it for me. And then to really cultivate a group of experts in your region that you can go to and run things by and say, what do you think? What does this sound like to you? That's always really, really helpful to have those people available to you. So now, once we've done all that, we still need to get down to deciding how we're going to craft a series of questions as to whether someone's capable or incapable with respect to a specific decision. And so here's another way of thinking about decision-making capacity. Does that person understand the information? Do they appreciate the relevance for themselves? And can they do a comparative and consequential kind of appreciation where they compare and contrast? Do we have a sense that they can rationally manipulate the information? And do they express a consistent choice? And so is there that flip-flop all the time? And what's that about? And that's often a really challenging situation where someone's not consistent. So you need to know the laws and procedures in your jurisdiction. As I mentioned, they're often framed this way: ability to understand information and ability to appreciate consequences of a decision or lack of a decision. So ability to understand information related to the decision. And again, ability is important, because do they have the ability, the cognitive ability, or is it because of other reasons? They couldn't hear us, they couldn't understand us. So really having to kind of hone in on, do they have that ability, and to provide the evidence to suggest that they do or don't, to override that presumption of capacity. So this capacity assessor that I was working with on Monday, the biggest challenge we were talking about was, one, accommodating to this gentleman who can't hear. So how is he going to communicate with him? But two, how to deal with the fact that this gentleman might respond, I don't know, to many of the questions he was going to ask him about his finances. So I don't know is an honest answer, but does it help the reader of that report truly feel comfortable saying that that person's not able to understand or able to appreciate? And so therein becomes like a roadblock. How are we going to get beyond the I don't knows to figure out whether this gentleman can understand and appreciate his financial situation? The I don't knows are sometimes your worst enemy, because they sort of stop things short, but they don't tell you whether that person's able to understand and appreciate. So the gold standard, there is no other gold standard, is a clinical interview. I'm not a big fan of the clinical vignettes where you talk to someone about a vignette and ask them how they would respond in that situation. I try to make it more specific related to them. There are certainly research protocols that run you through a series of questions that aren't vignette based. Probing and verifying, that's why you're doing this job, because you've got the clinical skills to keep asking them questions, keep them talking, and keep listening for evidence of capacity or incapacity. Help me understand, explain that more to me. I didn't quite get it. Could you elaborate on that? So that's your challenge. Your mission is encompassed in red in that little box, which is how to craft a series of questions that's going to get you at decision specific. So is it finances, treatment, etc. Probing of that person's insight and reasoning using examples from their situation. And so that's your mission. And you really want to get a sense of, do they appreciate that problem? So what does that person really understand about diabetes? Do they understand they have it? Do they understand what that means? Do they understand that their situation? And then the reasoning, consequential, comparative. Can they help you understand that they know that this choice might result in this and this choice might result in that? And can they compare for themselves personally, using their own personal values and situation, why they might choose one decision over one course of action over another? So that's kind of a quick run through, and we can talk more detail about how to do the interview and challenges. The final step is the documentation, which is really, really important, because in my life, I forget pretty quickly. After I've done 6 home visits, by the end of the day, they all begin to blur. So writing notes, documenting, trying to link that inability to understand and appreciate to a diagnosis or cognitive functional abilities. It's really nice if you can. You don't always have that ability to say that so-and-so has moderate Alzheimer's disease, therefore they have these kind of cognitive difficulties, which I was able to elicit in my conversation with them about their decision-making abilities with respect to their finances. And link it to predictable or potentially actual problems that would come. As a result of this, they don't understand that they're going to lose their apartment if they don't continue to pay the rent, that this is going to happen if they're going to lose all their money, that they could have these complications from the diabetes if they don't manage their insulin properly. So can you have a conversation with them about that and then document that? Try to use the language of the law in your jurisdiction. So read what the definition of capacity to X, Y, or Z is in your jurisdiction and use that language. In Ontario, if you're up above, in front of a consent and capacity board, which is our quasi-judicial board where someone could challenge their finding of incapacity, the first thing the lawyer is going to ask is, what is the definition, Dr. Cohen, of capacity to X, Y, or Z? So being able to go to the legislation and quote it chapter and verse is helpful. Direct quotes are fantastic. I asked this and the person said that. And then a start time and an end time, because sometimes people want to know, well, how long did you really spend with that client or patient? Was it just a cursory 5 minutes, or you really slogged through for an hour and a quarter? It's nice to be able to tell them, look, I really spent time doing that. It wasn't just a cursory thing. So let me quickly go to some specific areas of capacity, and then we can open it up for conversation. So capacity to consent to treatment was mentioned. This is one instrument. It's not the greatest for a more sophisticated audience, which I would call you folks a more sophisticated audience. It is called the Aid to Capacity Evaluation. It was put together by a group run by Ed Etchells, who's an internist in Ontario. And it really looks at a series of questions to help you elucidate whether someone's able to understand their medical problems, able to appreciate the choices. And then there's some questions in there for the non-psychiatrists in the group to make sure we're not missing depression and psychosis, and that you found someone capable, even though they believe they shouldn't be taking the insulin because it's poisoned by the Russians, etc. So it's a good tool. It's a helpful tool. It's one that you might share with your colleagues who are looking for a tool. And it's one that's quite straightforward and simple. With respect to capacity to manage property, again, the laws are very different in different provinces. Wadera has got an interesting article here about what some of the roles of clinicians would be. In different jurisdictions, they're different. So certainly we need to educate patients and families about the need for advanced financial planning and granting powers of attorney, to recognize signs of possible impaired financial capacity, and to actually do assessments in certain situations where you're supposed to. In our province, it would be only on the inpatient psychiatry unit where a psychiatrist or a physician would be doing that. It's no longer available to physicians outside of the inpatient psychiatry setting. Practical interventions to help people maintain financial independence, explaining direct deposit, direct withdrawal, and then to when to make medical or legal referrals if in your province it's somebody else doing those kinds of assessments. The article on the bottom right is an interesting review article on different kinds of measures. So if you're interested in more kind of research-based measures and some guidance on how to kind of think more broadly about what an interview would look like, that's a good review article. And Wadere's article is just really just thinking about what financial issues arise in older individuals with cognitive impairment. Capacity to live independently was brought up, and it is the biggest challenge, right? Can this person go home? Can this person continue to live independently? I'm often asked about that. In Ontario, it's pretty tricky because there's not a lot I can do with respect to my capacity determination that's going to make a big change. There might be in other provinces. And in my province, the capacity to consent to admission to long-term care is not, again, something I do. It is something our home and community coordinators do. It's not easily assessed in an office setting. It's much better to do it in a home setting. It's not determined by functional status or dependence. So we have many, many patients who are wheelchair bound and have other kinds of functional limitations, but they're able to cognitively, decide what the options would be and engage help in their situation. We need a lot of collateral about this. Capacity determination may not solve the problem. How will it be used? It's often not black or white. It's often very, very difficult. I think we need to sort of start exploring in the various domains, thinking about, how is that person managing in their home with respect to their personal needs and hygiene, their home environment, their IEDLs. So that hoarder, and again, it's so challenging with hoarding with respect to capacity, and what we would do about it, even if we found them incapable. Do they understand the risks and benefits of various treatment modalities? IEDLs, medical self-care, financial affairs, those all come into it with respect to capacity to live independently, because sometimes money makes a huge difference. If you're capable of managing a property and able to hire folks, then sometimes you can manage extremely well if you're lucky enough to have those resources. So here's where, it's tough. You want to probe insight and reasoning with attention to decision-making capacity. So, thinking about what they can tell you versus what you know from others about what they're able to do. So it's just fine, I'm managing just fine, but you've heard from everybody else they're not managing, or you can see from the fridge they're not managing, or you can just see from the apartment that they're not managing. So you want to have a discussion about how they perceive it and what you're perceiving, and then really kind of try to tease out the objective versus what you're seeing or hearing about their functional abilities. And the options to maximize their abilities and to minimize that gap between the demands and their abilities. This is my favorite question in red. I can't take credit for it. It was designed by someone, a lawyer, who used to be the head of the local consent and capacity board. I find it really, really helpful to try to get at the cognitive reasoning. How will you know it's time to get help or move? So I'm sitting in a lovely home in Midtown Toronto. The daughter's telling me it's a disaster. Mom won't do anything to let anyone in. She's not managing. She's not cooking. She's burning things, etc. So how's it going, Mrs. Smith? It's going great. Everything's fine. Well, how would you know it was time to get help or move? Oh, my daughter. I trust her completely. When she tells me it's time to get help or move, that's it. I know. She's the one. Well, as a matter of fact, your daughter is one of the reasons I'm here, because she's a little worried about you. Well, what does she know anyway? She's just a meddling son of a gun, etc., etc. Change the topic, come back again and start all over again. And you can hear there's a mismatch between that person's ability to understand their situation, the fact that they trust their daughter, but they cannot understand and appreciate that their daughter's got a concern. Then really thinking about this determination in my jurisdiction. So I find Mrs. Smith incapable of managing in her home. It's not going to solve the problem. It's not going to help the personal support worker get in the door to provide the bath, etc. We still need to figure out what else we're going to do. Did a home visit last week. I think it was my record number of egg cartons in the fridge. I think it was over 15. Before that, I think my record was a dozen. This was over 15. This lady's clearly not managing. She's clearly incapable, but even if I find her incapable, we still need a clinical problem-solving plan. So other issues, people have brought them up. fluctuating capacity. Many of these laws were never, ever designed for fluctuating capacity. And that's the huge issue with substance use disorders and many of the psychiatric disorders. And your colleague asked the most important question is how much do we go around the mulberry bush before we stop and say, we've got a lot of longitudinal history behind us to say, longitudinally, this person's not capable. And how do we deal with that? Capacity and risk. Often we're asked to see someone and talk about capacity because everyone's got their hair on fire because of risk. And so risk might help you decide where that bar is, but it's not going to determine whether someone's capable or not. One would want to factor that into the questioning. And then the role of clinicians versus others in the jurisdiction where you work. And that will differ depending on what kind of jurisdiction you work in. So that's a quick overview of some of the things that I've been thinking about with respect to assessment of capacity. With respect to some of the things you brought up, let's talk a little bit about substance use disorders. And that's a real tough one. Certainly, you know, in the context of someone who's acutely intoxicated, you have to decide whether they're capable with respect to treatment at that time, whether they're at acute risk when they might need to be certified or brought into hospital. But longitudinally, in Ontario, for instance, in my practice, and I hear the capacity assessors saying this often, is that often families hope that if we find someone incapable under whatever legal schema, that'll somehow deal with the alcohol use disorder or the other disorder. Often doesn't. It's wishful thinking. You know, I know families who've tried to go to court, for instance, in Ontario to get personal care guardianship, hoping that'll deal with it. And it might deal with part of it, but we still have a big problem. Sometimes I think one does have to stop and say, okay, maybe, unfortunately, there's enough evidence that because this person has been using substances for so long, that there might be permanent damage with respect to their brain, their cognition. And so if we go back and revisit their ability to understand and appreciate even when they're sober and when they're not intoxicated, we might find that unfortunately there's enough damage and water under the bridge that they really truly can't understand and appreciate. Now, again, whether that helps you solve the bigger problem of their using and coming back into hospital and not living the way their family would like them to, it may or may not. Sometimes it opens up a few doors, sometimes it doesn't, but it's a real problem. These laws usually weren't designed as much as families and frankly, care providers would love these laws to kind of come down and solve. At least in my jurisdiction, they don't. I would love to hear about other people's thoughts on that before we move on to some of the other topics. With respect to capacity laws and substance use disorders, what are people's thoughts on that?
And it's Terry here in Nova Scotia, Terry Chisholm. So I'm just going to say welcome everybody to turn on your cameras for the discussion part for the last little bit. And so I'm a geriatric psychiatrist, not a trainee, but it's interesting. Capacity is capacity wherever you go, but the legislation is quite different. So for example, in Nova Scotia, there's no specific financial assessors that are out there. The last few years, they've started training non-physicians to do assessments in general for overall capacity, you know, mostly about where people live, but there's very few of those people. So most of them go through the system.
Yeah, and I've met some of the people from different provinces who come to capacity assessor training just to understand the schema in Ontario. The other thing we don't have in Ontario, which exists in other provinces, which complicates all of this, and I haven't spoken to that, is different schemas with respect to supported decision-making versus substitute decision-making, right? Mm-hmm. So that changes things tremendously. In Ontario and in some jurisdictions, if someone's incapable, then a substitute decision maker makes decisions based on prior expressed wishes if possible, or best interests. In other jurisdictions, we've got supported decision making, and that's very different. Also interesting for intellectual disability community versus someone who's got a neurodegenerative process, right? So that I think on the ground, people are often engaging in supportive decision-making with their relative who's got mild dementia and then gradually transition to substitute decision-making, even though we don't have legislation in all jurisdictions like that. Any thoughts on substance use disorders and capacity or anything else that I've talked about?
I had a patient who that just kind of brought back the memories about. So he's a gentleman who's been drinking alcohol heavily for decades. He's had multiple rounds in the hospital where he'll sober up, and the internal medicine team will feel like he can go home, goes home, and it repeats. And so we were asked to do a capacity assessment on him. And at least to my knowledge in Alberta, there's no specific regulations around substance use and capacity. But what I ended up doing was factoring that into whether he could appreciate the reasonably foreseeable consequences. So in his case, he knew that he was going to go home and drink, but had no understanding that that would again lead to him coming into hospital because of a functional decline. And I think there was enough there that we felt that he lacked capacity, but that's how I tried to handle it.
Sounds very reasonable, but what door did that open, Raheem? So you found him incapable with respect to what?
Accommodation.
Accommodation.
So he the problem is when he goes home, he repeatedly kind of enters this Wernicke-like state. So he had left like raw meat on the counter and almost burned down the house. But it was a little bit, that was one where the capacity bar was that it was easier for us to find that he didn't lack that capacity. So he's awaiting placement now.
So what happens to me, given that I consult in the community and in long-term care, is then I meet this gentleman in long-term care, and then we have another kind of problem because he wants to go out and meet the buddies and go for a drink. And then long-term care is asking me to see about all these other issues. So it's really interesting to think about what happens next and where we're going to meet these folks. Because I totally agree, he needs to go somewhere and needs to be a housing solution. And then the question becomes a systems issue, because for me personally, there's not enough supportive housing for people like that. So these younger people end up in long-term care with 89-year-olds who have major neurocognitive disorder. And the other interesting challenge in Ontario that I've come across is that some of these people do really well in long-term care. The staff takes such care of them that they get even better as to that diabetes issue. And then they want to go home or want to go to another setting. And that's a really challenging issue. And that the law in Ontario talks about capacity to consent to admission to long-term care, but it's silent on capacity to be discharged from long-term care. And so we've had some fascinating cases where people have gotten a little better and want to go home, or they're no better, but they don't like it there. And then we're dealing with this vacuum. In Ontario, you have to, the home has to arrange a safe discharge plan. And sometimes there isn't a safe discharge plan. So we get stuck in this legal quagmire of there is no definition of capacity to consent to discharge from long-term care. So it'll be interesting to hear what happens with this gentleman and what happens on the other side of the fence when he gets to that facility and what they're dealing with. But I totally get it that some decision had to be made. And I think you made the appropriate choice to factor in his appreciation. And this sounds like there were dire consequences of his lack of appreciation.
Yeah.
Other thoughts, questions? Hoarding. That's an interesting one in terms of thinking about that. And then the insulin and the diabetes. Sorry, I apologize. Who brought that set of facts up?
That would be me.
Yeah. Okay.
Yeah. There was a similar interesting case where it was basically an individual who had more or less, the house was condemned actually by the city, significant hoarding, significant difficulties, resulting in physical health problems. Those had somewhat resolved in hospital with sort of that stabilized environment. And then, as I said earlier, just multiple steps in terms of during the assessment, they're even in hospital, trying to gather belongings in the hospital, not recognizing that that was potentially putting staff themselves, other patients at risk, etc.
Yeah. And again, finding an ethical and helpful solution for people with hoarding disorders is just a huge challenge, right? And then again, seeing people in retirement homes and long-term care homes who hoard, either because of hoarding disorder or because of a major neurocognitive disorder, and figuring out how to deal with that.
And that was the challenge we had, is your question that throughout what next, it was but we felt she was not safe to go home, that her home had actually been condemned. She was not legally allowed to go there by the city. So she was going to be going somewhere else. And she had been demonstrating the hoarding in the hospital.
Yeah.
So it's like how to
So
manage
still
it.
a clinical problem that you got to put your heads
Yeah.
together and feel how are we going to deal with that clinical issue, even in the new environment. Yeah. Yeah. I dealt with a resident who was consulting to a community agency, and they helped someone move. And we had bets on how long it would take before the hoarding became evident in the new place, and didn't take too long. How about the inpatient, outpatient one? Who brought that one up? Because that's a real common thing for me. And as I mentioned, this patient who's got delusional disorder. So I was getting emails all day yesterday, which is, yeah, we can start her on medication here, but every time she goes home, she doesn't take it. So what are we going to do? And
I brought that one up.
yeah, what are your thoughts on that? Is that the kind of situation we're thinking about? Like you can't, hide the medication in the food the way you might in long-term care or hospital, and who's going to do that? Is that we were thinking about?
Yeah, that situation, or you see someone even in a new consult, an outpatient, and family are quite concerned if they, for example, have acute psychotic symptoms for whatever reason, and they're not willing to take medications, and you think they're incapable, but there's not enough risk to warrant per se, like an admission, and you're kind of in this, how do we treat this person or manage any risk there is, but it's not enough to warrant an admission, where it's a bit easier to initiate treatment in those situations.
Yeah, those are so tough. I followed a patient for years with schizophrenia who managed to get married and was well enough to work, and then developed, midlife schizophrenia. And we worked for years. I mean, the nurse on my team was so patient with her husband to try to see whether he'd be willing to give her medications in whatever. Never happened. Unfortunately, he died. He died intestate. So there are all these other legal issues. And her two sons, both with schizophrenia themselves, one residing with her and one not, stepped up and were able to implement treatment by giving her the medication in, I forget what juice. And we had a lady who was totally different lady now that she was treated, but it was the husband was incapable himself of doing it for a whole host of reasons, but the son was able to. Without that, you're looking at, can you get an intramuscular in? Can you get someone hospitalized so you can start an intramuscular? And then you're really, as you commenting, like, when is someone certifiable such that you could bring them into hospital? And it's that lady was so unwell for so long. It was just so difficult. Never met criteria for admission. And it was years. I mean, and until her husband died that we could finally get her treated. So I don't know if I have any other answers for that. That's a toughie. Any other thoughts on that one, Vincent?
Oh, not specifically on that one, but one thing that I find difficult is when you have some reasonable family members who can understand the situation and appreciate how the patient is struggling at home is one thing, it really helps. But when you have not so much only the patient, but also whoever lives with them who do not understand. Like I had this patient recently who had like a throat cancer that was quite advanced and was really, really weak, like kept choking, could not move around. So it was really not adequate at home. But despite this, and despite like everybody in the clinic and home care, describing all these deficits in court, and even after the judgment, there was never recognition about any of that. And they actually ended up making a complaint. It was a whole thing. So I find that when family members don't get on, no matter how much you try to explain, these are some of the situations I find difficult.
I totally agree. I mean, trying to decide whether family members are capable, and I don't mean medical legally capable, that's only part of it, but whether they really are capable of dealing with these difficult situations is sometimes a challenge. And therein you feel like your arms are tied behind your back because you don't have the help you would normally need. And then sometimes in my situation, I've had the added crisis where the son or the relative doesn't want that individual to move because that's their housing. And if that person moves, then they can't afford to stay in that apartment, even though it's not the most expensive apartment, but it takes their mother's pension to pay for it. And so then you're dealing with that, there's a hidden agenda as well. In addition to the fact that there's a reason that person's still living at home, failure to launch, and there's other difficulties with them managing just their lives. So, you know, how to get help for that other person and how to work around that is really difficult. Yeah. It's so nice when you have support and you have a team to play with. When you don't have a team for a variety of reasons, it really makes struggles. And again, sometimes the finding a capacity or incapacity doesn't change that. You still have that problem that you have to deal with. Who brought up the case of the insulin and the diabetes? Because I think Rahim's story is kind of emblematic of that, right? That person who's going in and out of hospital, can't manage their diabetes and the insulin. And then at some point you might be able to get to the point where you decide they're incapable, but you still have that clinical problem is where are they going to live? Who's going to manage the diabetes and what are you going to do about that? So there's still that kind of issue, unfortunately. Harry, sorry, I interrupted you. Did you have a thought and comment?
Oh, I just thought of something from Amanda, what Amanda shared about the difficulty with the outpatient setting. And I think this is not mentioned, but I think we all agree that report is so important when we conduct capacity assessment. And this is especially hard when you're meeting someone new and you're just doing a capacity assessment. But in a patient who has like chronic illness like schizophrenia, who deals with issue with compliance, in Alberta we have the community treatment order where we can enforce compliance, but I find that tool has a double-edged sword because yes, you can force people into compliance with treatment, but in the long run they're just going to hate us as a profession, and they're just not going to really do well. But I find that when people need to really learn to appreciate the consequence, I think there's a balance between just giving them respecting their autonomy and letting them kind of understand the consequence, such as readmission to hospital, and then over time just build a case to present to them. Look, we've trust you, with these opportunities, but you didn't, make changes, and this is the time when we actually have to take that, decision making away from you, and we have to enforce compliance. I'm as a trainee, I'm learning to kind of find my balance of the risk tolerance, and I know that it's a very individual thing for every
Harry, it's so individual. For me in Toronto, I call it the front page of the Toronto Star sign. If I think that this story with this client is going to end up on the front page of the Toronto Star, then I get more anxious. But some of the team members I work with are much more chill. And so there's this tension about, my hair's on fire and theirs is not. And they're incredible advocates. It takes a team, it takes a lot of talking, and it takes support, and it takes a lot of personal reflection. What I don't have access to as much as I'd like, and sometimes is really helpful, is access to an ethicist. And I must admit, I don't go to our hospital ethicist as much as I should, because I'm lucky that I work in a hospital and I have access to an ethicist. And sometimes teamwork is amazing. Thinking and talking it out is important. And then just realizing that sometimes you can only do your best, but it is a team sport. And the more experienced you are, the more calm and comfortable you feel. But even then, as I say, for me, when I get to that front page of the Toronto Star sign, I just that inner sense of anxiety. But sometimes my team is just perfectly okay with it. And that's also an interesting tension, is you're dealing with a team that's both internal, like my own personal team that works out of the hospital, and then an external team of people who work at agencies or home care, and everybody's coming from a different perspective and also has different experience. So I often talk a lot about risk and get people to explicitly talk about how they're feeling about risk. And I even use Carole's very low-tech riskometer on a whiteboard. High risk, low risk, where are you feeling with respect to the situation? And let's see on that Likert scale where you feel, and then really let's talk about it. So I know we're at time. It was delightful to meet all you folks.